My name is Leila. I'm one of the registrars in the department at UCT and here. And this morning, I hope to cover the very broad topic of cancer of unknown primary, giving you a case presentation as well as an update on the management. The more I kind of read on the topic in preparation for this talk, the more I realized what a broad topic it is. So I hope I've covered all the salient features and also covered the important controversies, because there are quite a number of those. So I'll jump right in. So this is the outline of the talk. We'll start with a case presentation and then just go through the topic in terms of the different headings. So the case history. So the patient is a 61-year-old male. He had no significant past medical or surgical history and presented with a slow-growing right level 2 neck mass, which was not painful. He had no adenodysplasia, dysphonia, cough, shortness of breath, or hemoptysis. There were no nasal symptoms. There was no associated loss of weight, loss of appetite, or other constitutional symptoms. He had a 40-pack-year history of cigarette smoking. He was a farmer who lives on a small holding, and he had a performance status of 1. In terms of his examination, so he was generally quite well looking. There was no wasting. He on skin exam revealed no significant cutaneous lesions. He had on his neck right level 2 to 4 neck nodes, which were palpable. They were firm and non-tender, not fixed to the skin or any underlying structures. In his oral cavity, he had quite poor dental hygiene, but no tonsillar masses or asymmetry. He had a normal tongue, palate, and floor of mouth. In terms of his nasal exam, it was just normal anterior rhinoscopy, and his endoscope was normal. So we went on to do some special investigations. We started with an FNA, and that came back with malignant cells of uncertain origin. We also then did a core biopsy, which confirmed a diagnosis of a metastatic poorly differentiated squamous cell CA, which was P16 negative, but interestingly EBV positive. On EBV positive, his CT scan showed no obvious primary tumor or mass. It just revealed the right level 2 to 4 neck nodes. We also went on to do a PET CT, which I hope this image projects nicely, but shows just over here the right cervical nodal lesions, which were FDG avid. But there were no other areas of FDG avidity to suggest any other metabolically active area or primary or metastases. And you can see in this image also, it's just the neck nodes that show up as metabolically active. We went on to do a pan endoscopy for him on a thorough examination of the upper digestive tract. There were no macroscopic masses or lesions. We took multiple kind of random biopsies. We took from the skin, which showed a small skin lesion, which showed a moderate squamous dysplasia, but no invasive malignancy. We took from the base of tongue, which just showed reactive changes, and also from the nasopharynx, which showed a squamous dysplasia. And because of this, we did a repeat biopsy, which just showed an ulcerated polyp. And based on this, we came up with a staging of a T0, N3, M0 lesion. In terms of his management, so he was offered primary chemo-radiotherapy, which was very well tolerated. He had a complete clinical response, and he didn't require any surgical intervention. And on surveillance, clinically, he has up to his most recent visit, which was last month, he had no palpable masses in his or nodes in his neck. And on imaging, he had an MRI last month, which confirmed there were no soft tissue masses in the nasopharynx and his neck, or in oral or nasopharynx actually, and his neck nodes were all clear. So jumping into the topic, carcinoma of unknown primary is defined as a histological diagnosis of metastases without the clinical detection or radiological detection of a primary tumor. And as we know, if you've worked in a head and neck unit, many head and neck cancer patients will present initially with a neck mass, and the primary site of origin is usually identified over the course of the subsequent workup, but that's not the case in a carcinoma of unknown primary. A true, an SCC of truly unknown primary origin is actually quite a rare clinical entity in the head and neck region. and also the increasing sensitivity of various imaging, including PET-CT, as well as other interventions which I'll go through later, like transoral lingual tonsillectomy, has really enabled the detection of very small, microscopic and hard to identify oropharyngeal cancers, which has further lowered the incidence or rate of these unknown primaries. So further into the definition, so it's the clinical presentation of cervical lymphadenopathy with no obvious primary, and these patients must have a negative radiological assessment as well as a negative pan-endoscopy and tonsillectomy. In the literature, there's no real consensus though. So there's a liberal group which says you only need a negative radiological evaluation, and then there's a conservative group which insists that you must also have a negative pan-endoscopy and tonsillectomy before embarking on a treatment plan. At our institution though, we generally take the conservative approach, so we work them up as fully as possible. However, we do also bear in mind the law of diminishing returns, which I'll go through a little bit later. In terms of epidemiology and risk factors, so approximately 1 to 3% of all carcinoma of unknown primary makes up approximately 1 to 3% of all head and neck cancers, and the reported incidence is decreasing according to the literature. And this is owing to improvements in radiological imaging workup, also improvements in cytological analyses, as well as surgical advances. The most common histological subtype by far is a squamous cell carcinoma. And interestingly, with approximately 40% prevalence in European head and neck cancers, persistent HPV is emerging as a major risk factor for developing head and neck cancer. And further risk factors include smoking, alcohol, heavy alcohol use, and also Epstein-Barr infection. This graph on the side here just shows you how the incidence or reported incidence of occult primary head and neck cancers are decreasing over time. So in terms of the pathogenesis and the theories behind why we get this clinical entity, so the primary tumor, it's suggested, may remain diminutive or very, very small, microscopic, and it might escape clinical detection, or it might even disappear after seeding the metastasis. Carcinoma of unknown primary may be a malignant development that results in increased metastases survival relative to the primary tumor. It has also been suggested that it could be a branchiogenic cyst that then evolves or undergoes significant dysplasia and becomes a carcinoma, or it could be related to the host immune defenses which induce a regression of the primary tumor mass, but there's no similar type of regression at the metastasis site. So the presentation will therefore be of only a metastatic node. However, this theory specifically is not very widely accepted, and it's actually deemed highly questionable by some. In terms of molecular biology, so this has really made a huge difference in terms of making a diagnosis. So a PCR or immunohistochemistry has really helped in terms of picking up the primary at the molecular level and also suggesting a possible site of the primary. So if you get overexpression of HPV type 16 on your immunohistochemistry, that might indicate a tonsil or oropharyngeal malignancy. And if you detect any EBV DNA, Epstein-Barr virus DNA, this could indicate a tumor arising from the
Sorry, Leila, can you just check your sound?
Sure. Is that better?
That's much better, thank you.
Okay. So always keep in mind the differential diagnosis of a papillary thyroid CA. So in essence, we have two clinical scenarios when presented with the neck mass in the specific topic that I'm covering. So it can be, we've got a neck mass, and it can either be a suspicious mass.
Apologies, Leila, for interrupting you again. I think just check your internet.
Is that better?
Yeah, we can hear you now.
Okay. I think it's the internet. It's a little bit unstable. Just let me know. Okay, so moving on to the diagnostic protocol. So this includes, as always, a full clinical assessment, and that's a good and thorough history, a good and thorough examination, general examination, and then a focused head and neck exam, and also laryngoscopy, or a focused, or an FNE. We then move on to an FNA, and ultrasound guided is preferred to get the best possible specimen. And then we do cell block of HPV or EBV immunohistochemistry. And as mentioned earlier, oropharynx will be HPV positive generally, and nasopharynx might be EBV positive. And we then also try and do a core biopsy if FNA doesn't yield anything. Whether to do an ultrasound guided FNA, so this is quite well covered in the literature, and there was a big meta-analysis done in 2008 which showed that ultrasound guided FNA was significantly better than any other technique for sampling, and it has a sensitivity and specificity rate of 90 and 100% respectively. There was another older study from JAMA in 2000, and this showed that correct node stages were obtained in more than 90% of the patients using ultrasound guided FNA, compared to only about 2/3 where only palpation was used. In terms of imaging, so this should always be guided by your local MDT or tumor board protocols. Generally, we always, at our institution, we always do a CT of the skull base to the diaphragm. And however, it should be borne in mind that this is infrequently of value in very low volume head and neck tumors, and can yield nothing. MRI, and this you only do if you've got no answer from your CT, and however, some people argue, and especially in the developed world, they argue that all patients with disease in level 2 or 3 should have an MRI from the skull base to the neck to pick up tumors of the oropharynx, tongue base, or tonsillolingual angle. And then PET-CT, also very well covered in the literature. Some centers use this as first-line imaging, and then obviously a plain CT won't be done. It has been shown to be superior to CT alone according to multiple studies. However, it does have a significant false positive rate, and it's very, very important to bear in mind that you should always do this before you do any kind of biopsy. Just a little bit more on PET-CT, because it's so topical, it's so well covered. It is a well-established imaging technique in the workup of these patients, must be done before the biopsy. Some centers even accept it as a replacement for pan endoscopy and tonsillectomy if there's a cancer picked up on the PET-CT and your histology or FNA has a proven cancer in the neck. However, this is quite controversial, and it's also very dependent on the unit in which you're working and the discussion from your MDT. It's also not widely accepted for this to be done. And also it seemed to have come up mostly during the COVID pandemic because of limited access to theatre, and it was also an attempt to avoid any delays in the diagnostic and treatment process. So it's by no means routine. And it's also not for tumors less than 1 centimeter because of the size. Clinical evaluation, and if not clinical evaluation, then MRI would prove to be more helpful. So just some diagnostic adjuncts. So, or actually, these form part of the diagnostic pathway for these patients, more than just an adjunct. So pan endoscopy, it's a thorough examination under anesthesia of the upper aerodigestive tract, and the timing, it should always follow completion of all imaging, because any instrumentation or biopsy could compromise your findings, but also any subsequent imaging. Or you may find that earlier on in the diagnostic pathway, your imaging may have already identified a potential primary site for a targeted biopsy. And then the question of random biopsies comes up. So this is a long-standing practice all over the world. There's little evidence for it, but it's still a very common practice, especially if the positive lymph node follows the drainage pattern of a suspected index site. Then tonsillectomy also forms part of your diagnostic workup, and I'll go through that in the next slide. And also tongue-based mucosectomy, very topical at the moment as well. So this is shown to increase the yield of picking up SCC primaries, However, the negative or the downside of it is that it has an effect on your oropharyngeal function, and the actual impact on survival still requires proper prospective studies and evaluation. And also, it's obviously only offered in facilities where the expertise and technical aspects of it, instruments and things are available. Okay, so whether to do a bilateral tonsillectomy or not. So now in 2022, it's widely accepted that a bilateral tonsillectomy should always be carried out. And the rationale for a bilateral is that the incidence of synchronous occult tonsil tumors approaches up to 10%, which is deemed significant. And it also helps with your follow-up radiological assessments when you're looking at the patient's response to the response to your treatment and the tumor's response to your treatment. Okay, so this is a summary of the workup and the proposed pathway that we should follow. So we always start with it's basically a summary of what I've gone through, but it's quite nicely put out in this little kind of flow diagram. So you start off with your history and examination. You then try as much as possible to do an ultrasound guided FNA or just FNA if your facilities don't allow. If you get the diagnosis of an SCC, you then proceed to imaging, and we always start with a CT. Other centers might do a PET CT plus minus an MRI. If your imaging is negative, so then you would do your pan endoscopy, so endoscopic biopsies of the postnasal space, the base of tongue, and you might proceed with a bilateral tonsillectomy at that setting. If your imaging is positive, this then allows you to do image-directed biopsies, which is always preferred. However, if your image-directed biopsies are negative, you would then have to proceed to pan endoscopy, biopsy, and bilateral tonsillectomy. And if all of this is negative, then you sit down with your MDT or your tumor board and you discuss a treatment plan, which may or may not include surgery. It may be a combination of radiotherapy, chemotherapy, and surgery, or just oncological treatment. I'll go through this in the next few slides. Okay, just to consider differential diagnosis. So in a cystic neck mass, you should always, in HPV positive, you should always consider the following. So HPV positive head and neck SCC, papillary thyroid CA, as I've mentioned, or even a schwannoma. Another important thing to consider is any patient more than 40 with a suspected branchial cyst should be considered an SCC until you've proven otherwise. So even if the FNA is negative, you should follow the entire diagnostic pathway as for carcinoma of unknown primary. And if there's no disease on imaging, you can proceed to a selective neck dissection of levels 2 to 4 to help with your diagnosis. If it's a younger patient though, with no risk factors, you can then just excise the mass and wait for your histology. And this is quite a conservative approach, and this is what they use in the UK. If you still don't have an answer after you follow that entire diagnostic protocol, then you should really consider other things. So an undifferentiated carcinoma or even a lymphoma. You could have a distant primary below the thoracic inlet, like a lung or breast CA. You can also consider doing serum tumor markers like alpha-fetoprotein or beta-HCG, CEA, and PSAs. And then the question of a super selective neck dissection comes up. So super selective neck dissection isn't really very clearly defined, but most agree that it's about a level 2 to 3 dissection with clearing of all the fibrofatty tissue in that area, and it's not just removal of the mass. This is then in an attempt to confirm the diagnosis of SCC and also to stage the neck. When you can also proceed with treating the neck and hunting for the primary at the same setting, but it can also be done at a later stage. And this should be performed if the diagnosis is in doubt without compromising further treatment that you would have discussed at your MDT. So in terms of the diagnostic timeline, so there's lots of evidence to show that treatment in a timely manner results in better oncological outcomes. And you should aim for an MDT or tumor board discussion within 30 days of making a diagnosis according to global recommendations. But as we all know, this is not always achieved in our setting. There's severe resource constraints and we have very high oncology patient volumes. But it's just a guide, I guess, and a reminder that we should strive to get these patients kind of sorted within a timely manner because it translates into better outcomes. Okay, moving on to the topic of a tongue-based mucosectomy. So this is quite a novel and exciting addition to the management and diagnostic pathway. There's various techniques that you can use to do this, and there's endoscopic, laser, and robotic, and there's a multitude of diseases because it can actually be a talk on its own. It's so broad. The role though of this intervention is basically that it quickens these quite prolonged diagnostic pathways, because the way I'm speaking is as though you get the CT, you then don't have an answer, you can move on to your pan endoscopy and biopsy the next day or whatever, but it obviously in our setting doesn't happen like that. Practically these things take time, weeks, sometimes maybe even months. So this is said to quicken these prolonged diagnostic pathways because you can get an answer quicker perhaps. It also can help to de-intensify treatment because it obviates the need for pan-mucosal irradiation, which is often what these patients end up having because we don't know where exactly this tumor site is and where to target our radiation. And it can also help to reduce the radiotherapy dose. Interestingly, 2 out of 3 cases with otherwise negative investigations had an unknown primary tumor, which was identified by this specific diagnostic intervention. And then, as mentioned briefly earlier, the downside is that it has an effect on swallow function, and also we need a lot more prospective data on this. Okay, so going on from diagnosis now to management. So the management of head and neck SCC of an unknown primary is mostly directed at cure. So that's kind of our aim in most cases. Cervical lymphadenopathy represents disease that's loco-regionally advanced, but it's generally not found to be distantly metastatic in most patients, which is good. And this is in sharp distinction to any carcinoma of unknown primary, which arises from below the clavicles, where a finding of a supraclavicular adenopathy can actually represent incurable distant metastases, and there's a whole other clinical scenario. Okay, so primary surgery versus primary oncological treatment, and by oncological treatment, I'm referring to radiotherapy, chemotherapy, or a combination of those two. This is always discussed at an MDT and tumor board, and studies have shown that this kind of a meeting improves oncological outcomes significantly. So if at all possible, we should strive to have such a setup in the hospital departments or units in which we work. Primary surgery is sufficient treatment for N1 necks with no extra capsular spread, but in all other scenarios, it should actually be supplemented by some or other adjuvant oncological treatment. Primary concurrent chemoradiation with a planned neck dissection or salvage neck dissection based on response is also a valid alternative strategy. This table I thought was quite nice because it nicely lays out the end stage. So these patients are always going to be T0. So it lays out the end stage, what surgery you could implement, whether radiotherapy is needed or plus minus chemotherapy. But it's nothing here is kind of set in stone. We don't follow this word for word. And as I keep mentioning, it should always be discussed at the MDT. So that a proper treatment plan can be made. Okay, in terms of surgery, just kind of a summary. In N1 to N2B disease, this is small volume nodal. This is deemed small volume nodal disease, and so a selective neck dissection is generally done. In N2B to N2C disease, this is more bulky disease, and a modified radical neck dissection should be employed. And then in N3 disease, very big bulky disease, generally you do a radical neck dissection or a type 1 modified radical neck dissection. However, in these cases, as was the case in our patient, they will have primary chemoradiotherapy as opposed to surgical management. Okay, so I just included this this data to show that the outcomes are highly dependent on the nodal status. So over here we've got the disease-free survival, and on the Y And this is just another chart to show you that outcomes also are very highly dependent on HPV status. So these actually, HPV positive and HPV negative disease, should actually be considered as two distinct diseases in terms of their management and prognosis, because this is what the evidence shows. And this is actually reflected in the new TNM, which is TNM8, which actually downstages HPV positive disease. So as you can see from the chart, HPV positive disease. So this is again disease specific survival, and here we've got the time in months, and you can see quite clearly that HPV positive disease does much better than HPV negative disease. Okay, moving on further to, along the treatment protocol. So in terms of radiotherapy, again, to be discussed at an NDT or tumor board. It can be a combination therapy or just a complete alternative to surgery and the primary treatment. And in the field, obviously needs to include the NIC and any potential primary sites. So level 1, generally no radiation is recommended because of this potential extensive morbidity in this area. However, level 2 to 5 should always include the oro and nasopharynx. Okay, then whether we do uni or bilateral neck radiation. So there's quite a bit of controversy in the literature about this. The current evidence, according to multiple studies and a meta-analysis, shows that bilateral improves 5-year survival and you get less contralateral neck recurrence. However, it should be borne in mind that this obviously comes with certain issues, and the main one is there's more long-term toxicity, and then it always should be determined on a case-by-case basis at your NDT. This image I've just included because it shows the 5-year survival. It's according to various studies over time. And you can see that bilateral translates into better 5-year survival, and it's generally all significant. Okay, so this is a nice summary of the approach we use, and this is on the African Head and Neck Society website, and these are the guidelines that we use. Okay, so what's important is to try to identify the primary tumor, and then you need to really do a thorough history and exam and try and elicit symptoms that are related to the upper aerodigestive tract. In our country, it's very important to also ask patients about prior skin cancers, because these patients sometimes have a small lesion excised by maybe even a GP somewhere, and they don't think it's significant. Maybe it was never sent off for histology because the suspicion wasn't there, but it might be that was that the node they're presenting with now is as a result of that potential malignancy that they previously had. You need to have a very thorough kind of exam of the nose, nasopharynx, oral cavity, oropharynx, hypopharynx, larynx, all the way down, and even the thyroid. On palpation, palpate the tonsils, the base of tongue, examine for bleeding after you've palpated, because that's a telltale sign of something more sinister. If there's any cystic nodes, suspect something in the oropharynx or even the skin or papillary thyroid. The nodal location and laterality can actually suggest the location of a primary. I won't go through all the different nodal stations, but a level 1AB generally points to the oral cavity nodes or sinuses. And as you go down, a level 6 is going to more point to like something like a thyroid or subglottic hypopharynx, even esophageal malignancy. Immunohistochemistry is very kind of important. EBV suggests something in the nasopharynx, P16 or HPV points to something in the oropharynx, can even be skin. And then imaging, so CT, MRI or PET. Here we must remember the law of diminishing returns and additional costs with more than one imaging modality, even though international literature is very kind of encouraging for us to do multimodal imaging. We work in resource-constrained environments, and if we're not going to see any benefit or additional oncological outcomes with doing more imaging, then what's the point really? So we should always keep that in mind. And then a pan endoscopy, where we do guided biopsies, including a tonsillectomy. Okay, then we need to importantly exclude any distant metastases. Here we do a chest X-ray, CT, and maybe even a PET. We then stage the cancer and then sit down with our MDT, select appropriate treatment. Are we going for cure or palliation? And this should be discussed always with the patient. And then also you need to consider their general fitness to undergo any kind of intervention, whether it's surgery or oncological treatment, and also the patient's ability to deal with the consequences of the treatment that we offer. Okay, so that brings me to the end, and I'll conclude now. So this is a relatively uncommon clinical scenario entity, but it can translate into a very resource-consuming workup process. So this is important for those of us working in resource-limited environments, because most guidelines are actually from the developed world, where resources are kind of limitless and much more accessible, and they're quite encouraging of doing very thorough workups, even though this may not translate always into better outcomes. It's important to have a clear idea of the practice in your center according to different clinical scenarios, and follow the guidelines in your local unit. PCR and immunohistochemistry has really helped from a molecular level to detect about 50%, and if you combine this with the tonsillectomy, this has increased to 80%, and this does really help to de-intensify treatment according to the literature. And then also just important to remember that the overall survival of these patients is very dependent on two things, and that's nodal stage as well as the HPV status at diagnosis. Okay. Yeah, so that's the end of my talk. Thank you for your time and for listening, and I think we can have a discussion now and maybe take some questions. And those are my references.
Thank you, Leila, for an excellent presentation. Are there any questions from the audience? Prof. Fagan, are you on? I don't know.
Thank you very much, Leila. That was a great presentation, very thorough. Unfortunately, I don't think Prof. Fagan is able to attend today, but just a few comments. Obviously, you know, our philosophy is very much reiterated in the African Head and Neck Society guidelines, and that's generally the practice we practice here, and not necessarily all the aspects and protocols you covered in your presentation. You know, as always, we very much guided by the clinical examination, the history, and as you mentioned at the end, also the echelon nodal drainage patterns to suggest the underlying primary. We're quite stringent. We don't use PET particularly liberally, but there are some kind of scenarios where we will. And then just a few other comments. In the UK and the US, they also tend to use narrowband imaging as an adjunct, which also kind of does slightly increase your uptake of a small mucosal primary. In terms of immunohistochemistry, I stand to be corrected, but I think this is the one scenario where in the UK and US they'll actually ask for in situ hybridization as opposed to P16, because it reduces your risk of a false positive P16, which obviously is quite important in terms of your kind of management algorithm. And also, just to clarify for your understanding, P16 does not refer only to subtype 16, it covers all high-risk subtypes, including 16, 18, 31, and 33. And then the comment about random biopsies, I think again, as you mentioned, that's very much been replaced by kind of guidance by your imaging. especially PET. I mean, you tend to use PET to guide your biopsies. You wouldn't routinely randomly biopsy areas like the preform fossa, which some units will, unless there's been, the primary suggested clinically or in the history or by PET in that area. And then, as you said, basal tongue mucosectomy is very popular and is basically a mandatory part of many algorithms now. But just it's important that if you do a basal tongue mucosectomy, you have to stage it with the tonsillectomy. You can't do it concurrently because there's significant post-operative pain, and the other one is there's a high risk of oropharyngeal stenosis with subsequent scarring if you don't stage it. And then I just also wanted to comment on, in your algorithm, you suggested super selective or selective neck dissection when you have N1 to N2B positive nodal disease, which again I think is a practice probably more kind of relevant to other institutions where there's it's not really necessarily the practice of our unit. I think we would still very much probably perform a modified radical or functional neck dissection in positive disease. But you obviously have to take other factors into account, including the neck, the patient, the ability to follow up, and your resources.
Thanks, Matt.
Any other comments or questions from the floor?
And then, sorry, Leila, the one last comment is you also alluded briefly to carcinomas below the clavicles. I think the majority of those will probably be adenocarcinomas, and again, those follow a different obvious workup algorithm.
Yeah. Thanks.
Thank you, Matt. Are there no other questions from the floor or comments? Thank you, Leila, for an excellent presentation this morning. Thank you, everybody, for joining. There are no more questions. We'll conclude this meeting.
Okay.
Thank you.
Thanks, everyone.